Hello everyone, I'm Dr. Rachna Shanbag Moite, a pediatric immunologist and rheumatologist, and in today's video, we shall be discussing about BCG adenitis. When should one evaluate? BCG vaccine is the most common vaccine administered by the pediatrician in his day-to-day OPD. And as we know, the most common complication of this vaccination is BCG adenitis. BCG adenitis resolves on its own in most cases without receiving any specific treatment. In few individuals, especially the immunocompromised children, BCG vaccination can give rise to disseminated BCG infection, and this infection can be fatal. So in today's video, we shall be learning about how one can differentiate between BCG adenitis and disseminated BCG infection. What are the signs and symptoms of disseminated BCG, and when should one evaluate for an underlying immune deficiency? Let us start by discussing two cases. Both these children have received BCG vaccine at birth, and case number 1, who's a 4-month-old boy, presents to us with a left axillary lymphadenitis. He does not have any fever and otherwise looks well and active. Case number 2 is a 5-month-old boy, and he has presented with a huge red left axillary lymphadenopathy along with BCG site erythema and swelling, and on a closer look we find that he also has a diffuse papular skin rash all over his body. When we are to compare both these cases, in the first case, he only has a left axillary lymph node swelling, whereas in the second case, along with the lymph node swelling, there is also reaction at the site of injection along with skin rash. The first case, as we know, is a case of BCG adenitis. Whereas in the second case, when we see this classical presentation of BCG site swelling, diffuse papular skin rash, and left axillary lymphadenopathy, we must think of disseminated BCG infection. So how do we define disseminated BCG? The first criteria includes BCG should be cultured and identified by biochemical methods. Second, there has to be evidence of dissemination either in the form of a positive blood or a bone marrow culture, or presence of dissemination or infection at 2 or more anatomic sites away from the site of vaccination. That can be in the form of a lymph node, cutaneous abscess, gastric aspirate, etc. This, along with presence of a systemic syndrome compatible with mycobacterial disease in the form of fever, weight loss, anemia, etc. And when we satisfy 3 criteria, we call this definite disseminated BCG infection. So suspecting that the second child was not having a routine BCG adenitis, he was evaluated further. On examination, we find that he is febrile, has tachycardia and tachypnea along with pallor, and on systemic examination, he was found to have crepitations along with huge hepatosplenomegaly. He was immediately hospitalized and evaluated. On CBC, we find that he has anemia along with significant neutrophilic leukocytosis, thrombocytosis, and elevated CRP levels. An FNSE was carried out from the lymph node, a sample was taken for skin biopsy, and also a sample from gastric lavage was sent for staining. And as we can see, acid-fast bacilli was isolated from all these sites, indicated that there has been dissemination at the site of injection. This is what we call as disseminated BCG infection. Now, how do we differentiate between both these entities? BCG adenitis is an isolated axillary or supraclavicular lymph node enlargement, usually in the ipsilateral arm of receiving the BCG vaccine. There may be a cutaneous nodule at the site of vaccination, and there is absence of any local or systemic signs of inflammation. This is the most common complication of BCG vaccination. Whereas disseminated BCG, there has to be evidence of infection at extra-regional sites, such as in the form of liver abscesses, axillary lymphadenitis, etc., along with a systemic syndrome with lymphadenopathy, osteomyelitis, hepatosplenomegaly, fever, weight loss, etc. Usually, immunocompromised children are at risk of developing disseminated BCG infection, and it is relatively a rare complication of BCG vaccination. So coming to the important question, BCG adenitis, should one investigate? As we know, localized adenitis is known to occur in a small subset of healthy children, and that does not warrant any immunological evaluation. Whereas, if there is BCG adenitis in the presence of disseminated BCG, underlying immune deficiency, or a child suspected to have an underlying immune deficiency, or presence of significant family history in the form of sibling death, one needs to evaluate such children further. So, disseminated BCG is an immune deficiency unless proved otherwise. What are the common PIDs that present with disseminated BCG? One of them is severe combined immunodeficiency, or what we know as SCID. The second is chronic granulomatous disease, and the third is Mendelian susceptibility to mycobacterial disease. Why is it important to diagnose these conditions? It is because the treatment of disseminated BCG can often be challenging. BCG, as we know, is inherently resistant to pyrazinamide, and there is lack of consensus regarding the standard regimen of ATT and also the duration of treatment that must be offered to these children. Hence, most papers report various ATT drug combinations that have been tried, and most children are treated for a duration of 18 to 24 months. Suspecting disseminated BCG in this child and suspecting an underlying primary immune deficiency, immunodeficiency workup was carried out. The T cell, B cell, and NK cells in this child were within normal limits. However, serum immunoglobulin levels showed hypergamma-globulinemia. Since chronic granulomatous disease was one of the suspected PIDs, a DHR assay was carried out and was found to be abnormal. The genetic test showed a mutation in the CYBB gene, hence confirming the diagnosis of chronic granulomatous disease in this child, presenting as disseminated BCG infection. This child was further treated with ATT with the help of INH, rifampicin, levofloxacin, and ethambutol, and was further referred for a bone marrow transplant. So what is the take-home message? BCG adenitis with rash, one must think of disseminated BCG. If there is a BCG adenitis with fever and organomegaly, think of dissemination. And like I said, disseminated BCG is almost always a PID unless proven otherwise. And the most common PIDs that present in this way are SCID, CGD, and MSMD. Thank you.